Welcome back to our free Next Gen NCLEX review. We're so glad you guys are here. Happy Tuesday. We're just going to take a quick minute and make sure everything is up and running, and then we'll get started. This week we have kind of a fun combination of topics. We're doing tough topics, and today is definitely a tough topic, but we're going to make it easier for you guys. And feel free to ask us questions, drop some information in the chat, and we'll get started here in just a second. Make sure we're good to go. Good to go? Okay. We'll wait just another quick minute. I'll give you guys just a quick, while we're waiting to get started, I'll give you a quick refresher on our schedules. So make sure and tune in every Tuesday and Thursday at noon Central Time to your favorite social media channel. You can subscribe and follow so you can get updates on the topics that we're going to be discussing, and just stay tuned. Oh, okay, good to go. Okay, we got a green light, so we are going to get officially started. So again, welcome everybody to our free Next Gen NCLEX review. My name is Jackie, and I work here at UWorld on our nursing content team, and I'm so glad to be with you guys again today. As I mentioned earlier this week, our focus is tough topics. So today we're going to focus on COPD, and then on Thursday we're going to talk about electrolytes. So I hope you guys tune in, and as always, make sure you subscribe and follow to get updates on what we're going to be talking about. You can follow us on demand on Facebook and YouTube if you missed any of our sessions or want to go reference anything again. Another fun quick update I wanted to share, UWorld Nursing will be at the National Student Nurse Association conference this week down in Orlando. So if any of you guys are traveling down there to Disney, come check us out at our booth. We've got lots of fun things planned for you guys, so we hope to see you there. Again, today, COPD. We're going to talk through all things gas exchange. We're going to talk about risk factors, clinical features, interventions, and teaching for our clients for COPD. We're going to wrap everything up with a question, but we're going to save it to the end. And then we will walk through a couple other things as well, but make sure you put your comments in the chat and ask us questions. We have our team of experts on board that are here to answer any questions you might have. So with that being said, let's get started. Okay, so we're going to talk about, just as basic as we can, anatomy and physiology of our lungs. So basics first. First things first, we have two lungs. That's right, just two. We have a left and a right lung. So our left lung has two lobes, and it's a little bit smaller than our right lung because we have a little notch where our heart kind of rests in there. Our right lung has three lobes and is a little bit bigger. So let's talk about airflow. So we breathe in through our nose, which is going to warm and humidify our air. It's going to travel through our nose, our pharynx, our larynx, our trachea, which is like our windpipe. After the trachea, we have our bronchus, which is going to break apart into left and right. So bronchi is like plural bronchus, split a number of times and gets smaller and smaller each time. So kind of think of an upside down tree where the trunk is the trachea and the branches are the bronchi, and they get smaller and smaller until you get to the leaves or whatever is growing on the tree. So I want you guys to picture a bunch of grapes at the end of the tree branches. And I know grapes do not grow on trees, they grow on vines, but just visualize it with me. Okay, so we have air coming in through our nose, down our pharynx, larynx, trachea, or the trunk. From the trachea, our bronchi or branches are going to split and break off several times until we get to our bronchioles, which are where our grapes attach. And we call the grapes, the bundle of grapes, are alveolar sacs, and the grapes themselves are alveoli. So the alveoli are key for our discussion today because this is where gas exchange happens in our lungs and where the problems really lie for clients with COPD. So our respiratory system works very closely with our circulatory system. So our alveoli have very thin surfaces and have direct access to our capillaries. So our capillaries are responsible for picking up the oxygen molecules we breathe in and transporting them through our bloodstream, and then also dropping burning off the carbon dioxide or our waste gas that needs to be exhaled. So we breathe in and our blood picks up oxygen, it offloads the carbon dioxide, and we exhale that carbon dioxide. So start to finish one last time. We breathe in through our nose and our mouth, air travels through our pharynx, larynx, trachea, through our bronchi, which split a bunch of times till we get to our bronchioles, where those attach to our bundle of grapes or alveolar sacs, which have our alveoli in them. Through the alveolar walls, gas exchange happens, our blood picks up oxygen, offloads carbon dioxide, and we exhale that carbon dioxide. Okay, so that's how we breathe. Let's talk about a little bit more about our respiratory drive, or essentially what stimulates us to breathe. So our nervous system regulates our respirations by using pH, which is essentially a measure of the hydrogen ions in our blood. So the more hydrogen ions in our blood, the more acidic we are. So on the pH scale, our goal is to be right in the middle with a pH of 7.4. So acidic levels are lower and alkaline levels are higher than that 7.4. So when we have increased levels of CO2, this is going to increase the hydrogen ion concentration in our blood. So it's going to make our blood more acidic. Now, in a healthy client without any respiratory problems, a buildup of CO2, maybe from like a period of exertion like exercise, it's going to alert our brain that we need to bring in reinforcements to dispel that CO2. So this can look like stimulating our muscular system to activate accessory muscles to breathe harder or faster, or move our diaphragm more to get more air out of our lungs. So this is called a hypercapnic respiratory drive, or hypercapnic meaning elevated levels of CO2. So alarms go off when our CO2 levels are on the rise, and other systems are engaged to maintain that homeostasis in our blood. Okay, so that's hypercapnic drive, how we breathe, all of that. Let's talk about COPD. Okay, so we have an image that we're going to bring up just as a reference for the rest of our talk that you guys can look at. So COPD, which stands for chronic obstructive pulmonary disease, is a progressive, irreversible lower respiratory tract condition. So progressive and irreversible meaning we cannot undo the damage that it's causing, and lower respiratory tract, so we are going to be thinking about the end of our tree or a problem with our alveoli. So COPD is also an umbrella term for describing obstructive pulmonary lung diseases, so like emphysema and chronic bronchitis. Okay, so COPD has two defining characteristics when we're talking about the patho. So the first characteristic is airway obstruction. So clients with COPD have an inflamed airway, and airway meaning all the way down through into like our branches, into our bronchioles and our bronchi. And they also have increased sputum production. So this is going to obstruct air from filling our alveoli and air from escaping our alveoli. And this is really going to tie into the second characteristic. So first one, again, we have airway obstruction from inflammation and mucus production. And then we also have air trapping. So let me explain what this means. So in a normal client without COPD, the alveoli are like super elastic grapes, or like a stress ball. So when we inhale, they're going to expand, and when we exhale, they're going to deflate or squeeze air out. So in clients with COPD, the alveoli have really lost their elastic feature, and they're going to become more like a droopy raisin. So they are more like a static kind of raisin instead of a juicy, plump, squeezing grape. So this is going to cause air to get stuck, or air trapping to occur. So air just sits in the alveoli and it cannot get out. So think trapped CO2 in our alveoli. So let's put this all together. Because our alveoli are weak and droopy and our infrastructure is inflamed and full of mucus, it's harder for oxygen to get delivered and for our CO2 to leave. So we just talked about a hypercapnic respiratory drive. in COPD, since we said progressive and irreversible, over time our body adjusts to these chronically elevated levels of CO2, and they no longer become a trigger for breathing. So instead of having a hypercapnic respiratory drive, clients with advanced COPD typically have a hypoxic respiratory drive. So decreased levels of oxygen in our blood are what is going to drive our breathing. So again, clients with COPD become accustomed to these slowly climbing CO2 levels, and it no longer becomes a driver for breathing or for ventilation. Okay, I know it's just a lot to take in. There's one more thing that we need to think about when we're talking about the patho of COPD. So we have airway inflammation and obstruction from mucus and swelling, and we also have air trapping, so that's CO2 getting stuck in our alveoli. The other thing that happens is another structural change. So we are going to see changes in our lung tissue. So our lungs are going to become hyperinflated and enlarged from the air trapping. So just think of over time your lungs just kind of filling up with this trapped air. This is going to increase the size of our lungs, and it's also going to push down on our diaphragm or flatten it out. So the diaphragm is so important to help support our respiratory drive that by flattening it out, we lose a lot of its function. Okay, I know this was a lot and it's a lot of chemistry, but I hope you guys will go back, and if you want to listen to that again about the hypercapnic drive and the hypoxic drive, please do. But that's really the key fundamental about COPD and what drives a lot of its presentation and a lot of its complications. Okay, so we're going to take a minute, we're going to take a deep breath, we're going to do some gas exchange of our own, and I'm going to ask you guys a true-false question to see how you did. So make sure you drop your answer in the chat. So the question is true or false? Hypercapnia is high levels of oxygen in the blood. True or false? Hypercapnia is high levels of oxygen in the blood. I'm going to check our chat and see what we got. Let's see. Let's see, Brandon, Jacob on YouTube. Oh my goodness, things are flying. False, that is correct. Our friends on Facebook, amazing. False, very, very good. Ava on YouTube, false. Okay, very good, you guys. That's amazing. You guys have totally got this. Okay, so the answer is false. Hypercapnia is high levels of CO2 in the blood, not high levels of oxygen. Okay, good job. Well done. Okay, so let's talk about, this part's not as crazy as the patho. Let's talk about risk factors for COPD. These are going to be pretty obvious, but just think about them as irritants to the lungs. So think about things like smoking tobacco, prolonged exposure to respiratory irritants like air pollution, chemical fumes, smoke, dust, things like that. There's also a genetic component to COPD. So alpha-1 antitrypsin deficiency is one of those things that can increase our risk for COPD. So we'll just say, abbreviate that because it's a mouthful. AAT protects our lungs from damage caused by inflammation, so a lack of this protein increases our risk for COPD. Another risk factor is a history of recurrent respiratory illnesses in childhood. So think about asthma, pneumonia, bronchitis. So over time, that can cause some scarring of the lung tissue, which really increases our risk for the development of COPD over time. Pretty easy, nothing crazy here. Okay, so let's talk about clinical features. So what our client with COPD is going to look like. So these really focus on hypoxia over time and respiratory complications from our two main features of COPD, which again, air trapping and airway obstruction. So let's start with dyspnea or difficulty breathing. So dyspnea will start off as occurring at times of exertion, then it's going to progress to happening at rest. So it makes sense that we have a little bit harder time breathing when we're exerting ourselves, but when we have it at rest, we know there's some pretty significant complications happening in our lungs. Clients may also have wheezing due to that swelling of the airway and that mucus production. The air is going to have to work a little bit harder to get out, and we're going to hear some of those high-pitched sounds. Clients may also develop a chronic cough due to increased sputum, and it's going to become productive over time, so they're going to actually start coughing stuff out. Okay, next is our barrel chest. So I always remembered that this was associated with COPD when I was in nursing school, but I had no idea why. But I'm going to tell you why, in case you want to know, but it's important to know too. Okay, so bringing it back to our air trapping in the alveoli and hyperinflation of the lungs, as the lungs grow in size, our muscles and cartilage are going to have to remodel themselves to give the lungs more room to grow. So that's what results in our chest kind of taking on a rounded form instead of more of like an oval form. So this is the same idea when clients with COPD, we always learn too, they have a barrel chest and club fingernails, and I did not understand what that meant either. So what happens with COPD is essentially capillaries in our fingers and toes are very, very small, and we become hypoxic. We don't get oxygen, and because of that, it causes them to remodel and grow new blood vessels, which causes them to get larger and develop that bulbous appearance. So we're having to remodel more and more to get more oxygen to the farthest part of our body. And when we do that, our fingers kind of become packed in with capillaries, and then that causes our nails to become round and bulbous. Okay, lastly, we have fatigue from hypoxia. Since we have decreased circulating oxygen in our bloodstream, anything requiring an exertion of energy is going to fatigue these clients since they have low levels of oxygen. So again, fatigue is so closely related to hypoxia. So quick recap on what our clients with COPD are going to look like. Think dyspnea, difficulty breathing. Think cough, productive, a lot of mucus. Barrel chest and club fingernails because of the remodeling that's happening in our lungs and also the remodeling that's happening in our distal extremities. And fatigue. They're going to have a hard time breathing. Everything's going to be harder. Okay, next up, diagnosis. Okay, there's a few ways to diagnose COPD, but we're not going to spend like a ton of time on this so we can get to more of the good stuff. So think about spirometry. So this can be used to measure the amount of inhaled and exhaled air during the respiratory cycle. So a client with COPD is going to produce low levels of expiratory pressure. So it's harder for them to get that air to move out of their lungs and expire. We can also do chest x-rays. So on a chest x-ray, we're going to see what we call blebs, which is going to indicate that air trapping in our alveoli. Lastly, we can monitor our arterial blood gases, or our ABGs. So clients with COPD will have an increased CO2 and a decreased O2. So this means that they have respiratory acidosis. So we'll do later on an ABG session for you guys, but just know clients with COPD, if you take a blood gas, they're going to appear to have respiratory acidosis. Again, that buildup of CO2 in our blood is what really is going to cause our blood to become acidotic or acidic. Okay, so COPD has some pretty big complications from it, so let's jump in. First, let's talk about pulmonary hypertension. So bringing it back to our two basics of air trapping and inflammation, our vessels have to remodel themselves, and this increases the pressure in our pulmonary arteries. So we mentioned this in our heart failure live and learn, but when we have hypertension, no matter where it is, it's similar to our blood having to run into the wind. So same principle here with blood going into our lungs. So over time, pulmonary hypertension is going to lead to right-sided heart failure, or cor pulmonale, and this is going to cause fluid to accumulate throughout the body. So we did another learning session on heart failure. I encourage you guys to go check that out too, and you can really learn the difference in left and right heart failure. But I'm going to take a minute and pause there, and I want you guys to use the chat again. If you watched the session on heart failure, if you didn't, drop in the chat some findings that are associated with right-sided heart failure. Again, we'll take a quick pause there. I'll check the chat. Drop in the chat some findings associated with right-sided heart failure. Let's see what we got. Awesome. Brandon on YouTube, JVD, that is the first thing I have on my list. Very good job. Amon on YouTube, edema, yes. Jacob, all of those, edema, JVD, liver. Kadeen on YouTube, JVD, very good. Facebook, I'm seeing some things come in too. And TikTok, yes, very good. Ascites, edema, swollen leg, yes. Awesome, guys. Very good. More coming in from TikTok. Thank you guys so much. Okay. I think you got it. You must have watched our session, or you just know it. Either way is great. Okay, so right-sided heart failure can look like JVD or jugular venous distension. So again, we think about blood backing up into our body when we think about the right side of our heart not working. So that's where blood is entering our heart. So when we have dysfunction there, blood is going to back up into our body. So that can look like ascites in our abdomen, edema in our extremities. So clients will have an increased risk also of pneumonia and respiratory failure when they have COPD. Okay, so let's move on to long-term management. Again, COPD is progressive. It's a long-term condition, so we need to think about the big picture. So starting off, let's talk about our modifiable risk factors, which is smoking cessation. We want to encourage these clients to stop smoking. It's just going to make our lungs worse. It's going to make the condition progress quicker. So smoking cessation, number one. We also want to encourage pulmonary function with pulmonary rehab. So we want to slow that progression as much as we can. So that's what rehab is really good for. And also, again, about assessing our baseline function. We also want to reduce the risk of acute COPD exacerbation. So a lot of time that stems from infection. So we want to educate our clients about vaccinations like the flu vaccine, the pneumonia vaccine, anything that can reduce their risk of an infection kind of infiltrating into the lungs. Let's talk about medications. Okay, so medications for chronic COPD can include inhaled long-acting bronchodilators, so long-acting here. These are given to open the airway. So we would give things like salmeterol, which is a beta adrenergic, and tiotropium, which is an anticholinergic. So if you guys remember, I don't even remember what we talked about it with, but we did talk about anticholinergics. But one of the effects of anticholinergic medication is to dry up secretion. So that's going to help with some of that mucus production. We also will give things like inhaled corticosteroids, which are given to reduce swelling in the lungs. And we'll also give expectorants, which are given to thin out mucus. So that'll allow the client to actually expectorate it out or kind of cough it up and get it out. An example of that is guaifenesin. Okay, just everyone tune in. This is the big kicker with COPD. And I think we have a good foundation of what's happening with our gases when we talk about COPD, that this is really going to make sense. But this is definitely one of those kind of principles we really want to kind of make sure you guys understand. Okay, supplemental oxygen. So this is where the whole long story of gas exchange is really going to come into play when we talk about COPD. So we said clients with COPD respond to a hypoxic respiratory drive instead of a hypercapnic respiratory drive. So when we give clients with COPD supplemental oxygen, we want to be sure that we are only giving it to maintain an oxygen saturation between like 88 and 92%. Usually like the magic number is 90%, and I'm going to tell you guys why. So if we try to get our COPD client to have oxygen saturation that's greater than 95%, we can actually cause them to hypoventilate or underbreathe, or breathe too shallowly or too slowly. So again, a client with COPD is blunted from responding to a hypercapnic respiratory drive because it has grown so accustomed to these rising CO2 levels that it's like, meh, no big deal. Instead, it's listening to oxygen levels in our blood. So if we force a bunch of oxygen into our client, how that hypoxic respiratory drive works, it's going to see all that oxygen and be like, oh great, the lungs are crushing it. There's no need for me to breathe as hard as I'm breathing. So it's going to suppress our breathing. So again, giving oxygen to a client with COPD that is giving it at high levels, it's going to blunt the respiratory drive and they're going to hypoventilate or breathe too slowly or too shallowly. So that's why we don't want to do that. We want to keep them at 90%. So again, as we've always said, the NCLEX is an exam all about safety. So this would be a good takeaway to remember from today's session. We do not want to over-oxygenate clients with COPD because it is not safe. We want to elect to deliver oxygen that's titrated to the lowest amount to maintain them around that 90% saturation with rest, exercise, and sleep. So anything we're doing, we should try and keep them at 90%. Okay, so that's chronic management of COPD. Let's talk about acute management of COPD, or when a COPD exacerbation happens. This is something I saw in nursing school. I think it was one of the first clients I saw in the hospital. Okay, so starting with medications, we can expect to give meds that are quick actings, like nebulized bronchodilators, and these are, again, going to open the airways in our lungs, and then we're also going to give anticholinergics, but quicker acting ones to help dry up secretions. So think albuterol and ipratropium. We'll give oral or IV steroids to reduce that swelling and inflammation. And we're also most likely going to have to give antibiotics. These are typically started because this exacerbation is brought on by an infection. So we're going to have to get to the root cause of the problem, which is typically an infection. Clients may also need respiratory support like BiPAP or even intubation in extreme cases. So we're going to have to take over the function of the lungs for them. Okay, we're in the home stress. Last topic is teaching. Teaching is all about how these clients can get the maximum respiratory function out of their lungs. So you can expect to teach them things like airway clearance techniques. This can look like percussion or vibration on their back to help loosen secretions and help them cough them out. We can also teach them about postural drainage techniques, so repositioning themselves to move drainage from a different part of the lung. Again, the whole point is trying to get that mucus out of our lungs. We can also teach them about a huff coughing technique, and I'll kind of describe this for you guys, but this is, again, a way to clear the airway by engaging our abdominal muscles or our stomach muscles. So what we're going to do is we're going to instruct the client to inhale through their nose and relax their abdominal muscles. So it's kind of like sitting like this. Then they're going to lean forward and exhale sharply with 2 to 3 huff sounds. And they're going to contract their abdominal muscles, and this is going to cause the mucus to kind of come up so they can cough it out. So that huff sound is like the like kind of someone knocks the wind out of you, and that's what you want to teach them to do. We can also teach them about the tripod position to help relieve some of the work of breathing that is happening. So think of a tripod as you're making a triangle with like your lap, your abdomen, and your arms, and kind of having them lean on a table to breathe. It's going to increase the surface area for our oxygen exchange, and it's going to relieve some of the pressure on our diaphragm. We'll also teach them about pursed lip breathing. So what happens with pursed lip breathing is it's going to allow that negative pressure to expand our airway and allow more air to come in and fill our capillary or fill our alveoli, and air to get out easier too. So we'll teach them to inhale and exhale slowly through their mouth through a pursed lipped structure with their mouth. So they'll breathe in through their nose and exhale slowly like this, like that. And that's going to help open up their airways a little bit more. We'll also teach them about implementing humidified air in their house. So again, that humidified air is going to kind of act like our nose, and it's going to help us thin secretions when we inhale it. We're also going to want to encourage these clients to maintain hydration, drink at least 2 liters of fluids a day, and then nutrition is a big part of this. So when we talked about kind of what's happening with our lungs, like our lungs are growing, and our body is kind of designed where everything has just enough space. If our lungs are growing and we're eating a huge meal and drinking a lot of water, our stomach is going to expand, and it's going to make breathing harder. So we want to teach them to have small, frequent meals, to drink in between meals instead of with meals, to kind of allow more room in our stomach for food. We want to really pack in as much nutrition as we can with like high protein meals, and we want to avoid foods that are going to cause like gas production, any gassy foods like vegetables like cauliflower and broccoli. We want to encourage them to avoid those cruciferous vegetables, if you will. Okay, that was it. That's what we have for COPD. We're going to bring up our question and see how we did. So we'll go ahead and bring that up, and then I will read it, and feel free to drop your answers in the chat. I'll give you guys a little bit of time to answer, and then I'll walk through the explanation with you. Okay, so what we have is the nurse is talking with a client with chronic obstructive pulmonary disease who is reporting recent weight loss. The client states that bloating, exhaustion, and dyspnea make eating difficult. Which of the following responses would be appropriate for the nurse to make? select all that apply. So again, we're talking COPD, we're talking client education, and we know select all that apply, so we're going to have more than one right answer. And for this, we're looking for appropriate responses, so we're going to be looking for true, like if we take a true-false approach to the options, we're going to be looking for the true statements. Okay, so option 1, use your bronchodilator before meals to increase the work of breathing while eating. Okay, I'm actually going to pause there. I want to see if you guys have answered, and I want to see what everyone's thinking. Feel free to drop your answers in the chat. Maybe I'll give you guys a couple of seconds to respond and answer, and then I will walk through, because I don't want to answer my own question. I'd rather you guys answer it. Let's see what we got. Boop, boop, boop. I'm starting to see some things come in. Awesome. Okay, Facebook. I'm seeing answers come in. Janat, good job. Let's see, I'm seeing a bunch come in on YouTube. You guys are definitely getting these. Facebook, TikTok is starting to come in too. Thank you guys so much. Awesome. Okay, very good. Okay, so I'll go through this. So we have option 1, use your bronchodilator before meals to decrease the work of breathing while eating. This is a true statement. This is definitely something we can do. We can open our airway, allow us to have a better chance of getting our meal and reduce our work of breathing. That is a true statement. Okay, option 2, drink fluids between meals instead of immediately prior to or during meals. This is also a true statement. So again, we just talked about that. We want to reduce the pressure that's happening on our lungs. So we want to drink, kind of split up our food and our liquids, not do it all at the same time. So that's a true statement. Option 3, increase your intake of high fiber foods such as broccoli and cabbage. Those are going to be our gassy vegetables. We're not going to want to do that. So we want to take in high fiber foods that are not going to produce gas like broccoli and cabbage are. Those are cruciferous vegetables that we talked about. So that's a false statement, not a correct answer. Option 4, take a short walk before each meal to help stimulate your appetite. We definitely don't want to overexert ourselves before eating. This is not going to help a client with COPD. It's going to make them even more out of breath or have even more dyspnea. Option 5, eat small, frequent meals that are high in calories and protein. This is a true statement. We definitely want to eat small, frequent meals. Again, we don't want to stuff our stomach to put more pressure on our lungs. So that our correct answers are options 1, 2, and 5. So good job, you guys. Please, again, we appreciate you guys joining us. Come back on Thursday for our next tough topic, which is electrolytes. Come and see us if you guys are in Orlando at NSNA. We'll be there. And then always remember, subscribe and follow us at UWorld Nursing on your favorite channel so you can get updates and information about all of the great things that we have going on here at UWorld. We have our 7-day free trial. Check it out. We have links available for you guys, so just click to that directly or go to nursing.uworld.com and check us out. We know you won't regret it. Thank you guys again, and I guess I'll see you next time. Bye.